Hello, my name is Lilian Wang, and I am a breast imaging radiologist at Northwestern University. Today I will be discussing our work entitled Pathologic Outcomes in Single versus Multiple Areas of Architectural Distortion on Digital Breast Tomosynthesis. This is currently in press. Architectural distortion is the third most common imaging appearance of breast cancer and accounts for 12 to 45% of missed cancers on 2D screening mammography. It is defined as thin straight lines or spiculation radiating from a point, or as focal retraction, distortion, or straightening at the anterior or posterior edge of parenchyma. It may be associated with asymmetry or calcifications and can also be an associated feature of a mass, as seen here. Digital breast tomosynthesis improves cancer detection and reduces recall rates compared to digital mammography alone. Increasing DBT utilization has led to increased identification of subtle findings previously occult on DM, including AD. And here we have a nice example of that where we can much better appreciate this small mass with associated distortion on DBT compared to DM images. Higher recall rates for AD have been observed with DBT compared to DM, as summarized in this table here, with concomitant decrease in the positive predictive value of biopsy, indicating that AD detected on DBT is less likely to represent malignancy compared to that identified on DM. Nevertheless, biopsy is warranted given a pooled PPV for malignancy of 34.6% in a recent meta-analysis. Although experience with AD is growing, several challenges remain. First, inter-observer variability for AD is considerable. Studies have shown that agreement among radiologists for AD is only fair, with kappa values of 0.29 to 0.67. Another study showed that 3 readers agreed on the presence of AD in only 26 of 51 recalls for AD. There are also lower levels of inter-observer agreement for AD compared to masses, and significantly lower sensitivity for AD versus non-AD findings. Here we have 6 examples of questioned architectural distortion. The 2 on the right were felt to represent superimposition after additional diagnostic imaging, whereas the remaining 4 cases were felt to be persistent, and tissue sampling was pursued, demonstrating the following pathologic diagnoses. Another challenge of AD is that management was difficult prior to availability of DBT-guided biopsy. If no ultrasound correlate was identified, some patients proceeded to MRI to identify a potential MRI correlate for biopsy, whereas other patients underwent excisional biopsy using DBT-guided needle localization. Another challenge is a reported higher rate of radiology pathology discordance for DBT compared to stereotactic biopsy of AD. And this highlights that the subtle nature of AD at imaging can be difficult to target during biopsy. Careful assessment of rad path concordance and review of post-biopsy DBT images is necessary to ensure adequate sampling. In addition, more data is needed on the spectrum of benign entities that may account for AD so that we can have increased confidence in assessing for rad path concordance. With increased detection of AD, radial scars are also diagnosed with increased frequency, and management of this entity is controversial and evolving. While traditionally surgical excision has been recommended, surveillance is now often pursued, given low upgrade rates reported in recent literature. And we've all encountered this scenario as well, where it seems that everywhere you look, you can see areas of architectural distortion. And management of AD, particularly multiple AD, remains uncertain. In addition, there is no data addressing histopathologic outcomes in patients with multiple AD or the potential association of multiplicity of AD with such outcomes. Therefore, the purpose of our study was to compare pathologic outcomes between single and multiple areas of AD identified on DBT undergoing image-guided biopsy. This was an IRB-approved retrospective study of patients undergoing image-guided biopsy of AD without associated mammographic mass or asymmetry over a 2-year period. Inclusion criteria included consecutive patients presenting for image-guided core needle biopsy of AD, and exclusion criteria included mass or asymmetry as a dominant mammographic finding, AD that was not identified on DBT, and patients in whom biopsy of AD was canceled. Mammography exams were performed in combo mode consisting of DM, DBT, and synthesized DM images. Screening exams comprised of MLO and CC views, and diagnostic exams consisted of lateral and spot compression images. Ultrasound was performed using a 16.5 megahertz transducer, and MRI on a 1.5T system using a 16-channel bilateral breast coil. Exams were interpreted by one of 16 fellowship-trained breast imaging radiologists with the following years of experience, with the vast majority having 6 to 10 years of postgraduate training experience. Exams were interpreted utilizing BI-RADS terminology. Ultrasound biopsy was performed using 12 or 14 gauge spring-activated biopsy devices, typically with 5 samples, and DBT-guided biopsy was performed on a prone DBT system with a 9-gauge vacuum-assisted biopsy device, typically with 6 samples. Pathology was reviewed by the radiologist performing the biopsy to determine concordance. The following patient characteristics were extracted from the medical record: age, breast density, family history, personal history, high-risk status, concurrent breast cancer, and concurrent high-risk lesion. The following imaging features were also recorded for each lesion, including how the AD was detected on screening versus diagnostic exam or first versus subsequent DBT exam. We also evaluated for presence of an ultrasound correlate, method of biopsy guidance, and whether or not MRI was performed. If MRI was performed, we recorded the indication, presence of an MRI correlate, and type of MR enhancement. Patients were classified as having single versus multiple AD based on the presence of distinct areas of AD in clinical reports. For multiple AD patients, DBT images were reviewed to classify multiple ipsilateral AD as being in the same versus different quadrants and to record the distance between biopsied areas. Pathologic outcome was recorded based on most aggressive pathology on either core needle biopsy or surgical excision, and was categorized as benign, high risk, using the following hierarchy: ADH greater than radial scar, greater than papilloma, FEA, and lobular neoplasia, or malignant, including DCIS, invasive ductal carcinoma, and invasive lobular carcinoma. In patients with multiple AD, most aggressive pathology was recorded both at the lesion level and the patient level. For benign and high-risk AD that did not undergo excision, follow-up records were reviewed for evidence of malignancy and length of follow-up. For statistical analyses, the Wilcox and rank tests and Fisher's exact tests were performed to compare single and multiple AD groups. The multivariable generalized estimating equation model was used to identify independent predictors of malignancy at the patient level, with a p less than 0.05 considered statistically significant. During the study period, there were 416 patients who presented for image-guided core needle biopsy of AD. One patient was excluded as the dominant finding of mass or asymmetry on mammography. Another 6 patients were excluded as the biopsied AD was not detected by DBT, and another 7 patients excluded as the biopsy procedure was canceled. This resulted in 402 patients with biopsied AD, 372 patients with single AD, and 30 patients with 66 AD in the multiple AD group. In both these single and multiple AD groups, approximately 2/3 of biopsies were performed under DBT guidance, and the remaining 1/3 performed under ultrasound guidance. Of the 30 patients with multiple AD, 23 or 76.7% had 2 visualized AD, 2 or 6.7% had 3 visualized AD, and 5 or 16.7% had 4 or more visualized areas of AD. In terms of biopsied AD, 1 patient had a single biopsied AD, 24 patients had 2 biopsied AD, 19 ipsilateral and 5 contralateral. 3 patients had 3 biopsied AD involving both breasts, and 2 patients had 4 biopsied AD involving both breasts. The distance between ipsilateral biopsied AD ranged from 15 to 88 millimeters, and 6 patients did not undergo biopsy of all visualized AD. This table compares patient characteristics for patients with single and multiple AD with no significant difference between groups in terms of age, breast density, personal history of breast cancer, or high-risk status. In contrast, a significant difference was seen between groups in terms of family history, with those in the single AD significantly more likely to have a family history of breast cancer compared to those in the multiple AD group. Compared to the single AD group, patients with multiple AD were significantly more likely to have concurrent breast cancer and concurrent high-risk lesion. In terms of imaging characteristics, no significant difference was identified between single and multiple AD groups in terms of type of examination showing AD or presence of an ultrasound correlate. This table summarizes the pathologic outcomes in the single and multiple AD groups. Malignant pathology was seen in 28.2% of single AD cases and 31.8% of multiple AD cases. ILC comprised a significantly greater fraction of malignancies among multiple AD than single AD. High-risk pathology was seen in 32.5% of single AD and 53% of multiple AD, with radial scar being the most common high-risk lesion in both groups. Benign pathology was seen in 39% of single AD cases and 15.2% of multiple AD cases, with stromal fibrosis being the most common benign entity. The frequency of malignancy was not significantly different between multiple versus single AD on either a per lesion or per patient basis. However, frequency of high-risk pathology was significantly higher for multiple compared to single AD on a per lesion, but not per patient basis. In addition, radial scars accounted for a greater proportion of high-risk lesions in multiple compared to single AD. The frequency of either high-risk or malignant pathology was significantly higher for multiple than single AD on both a per lesion and per patient basis. Univariable associations between frequency of malignancy and various patient and lesion level characteristics were also examined. Of the following patient characteristics, only concurrent breast cancer was significantly associated with malignancy. Of imaging characteristics, presence of an ultrasound correlate was significantly associated with malignancy, whereas the examination showing AD was not a significant predictor. Multiplicity of AD was also not a predictor of malignancy in biopsied AD. In patient-level multivariable analysis, the only significant independent predictor of malignancy among all patients was concurrent breast cancer, and the only significant predictor of a lower risk of malignancy was a concurrent high-risk lesion. In patients with single AD, personal history of breast cancer was a significant independent predictor of malignancy, and in patients with multiple AD, concurrent high-risk lesion was a significant independent predictor of a lower risk of malignancy. Shifting now to follow-up of high-risk and benign lesions at biopsy. In the single AD group, there were 121 high-risk lesions. 116 were high-risk at biopsy, at which 3 of 84 were upgraded to malignancy at excision. 9 were diagnosed as high risk at excision after benign biopsy, and 1 myeloid sarcoma was diagnosed at excision. Of 121 high-risk lesions, 89 were high risk at excision. 28 showed no evidence of malignancy after a mean of 40.4 months of imaging follow-up, and 4 were lost to follow-up. In the single AD group, there were 20 radial scars with atypia at biopsy. One with ADH was upgraded to DCIS. There were 65 radial scars without atypia at biopsy. 47 were excised without upgrade to malignancy. One myeloid sarcoma was diagnosed at excision. 15 showed no evidence of malignancy after a mean of 38.5 months of imaging follow-up, and 2 were lost to follow-up. An additional 8 radial scars were diagnosed at excision after biopsy demonstrating lobular neoplasia or after benign biopsy. In the single AD group, there were 157 benign lesions at biopsy. 15 were excised due to discordance, demonstrating 3 invasive ductal carcinomas, 6 radial scars, 1 ADH, 1 lobular neoplasia, and 4 benign lesions. 5 benign concordant lesions were also excised, demonstrating 1 lobular neoplasia and 4 benign lesions. Of 145 benign lesions, 8 were excised without upgrade. 121 showed no evidence of malignancy after a mean of 34.8 months of imaging follow-up. 1 developed cancer at the AD site after 33 months, and 15 were lost to follow-up. In the multiple AD group, there were 35 high-risk lesions. 34 were high-risk at biopsy, of which 1 of 26 was upgraded to DCIS, and 2 were diagnosed as high-risk at excision after benign biopsy. Of 35 high-risk lesions, 25 were high-risk at excision. 6 showed no evidence of malignancy after a mean of 24.2 months of imaging follow-up. 2 were lost to follow-up, and 2 were removed during mastectomy for ipsilateral breast cancer, limiting correlation with surgical pathology. In the multiple AD group, there were 4 radial scars with atypia on biopsy. These were all excised without upgrade. There were 26 radial scars without atypia, of which 17 were excised without upgrade. 6 showed no evidence of malignancy after a mean follow-up of 24.4 months. 2 were lost to follow-up. 1 underwent mastectomy for ipsilateral cancer, and 1 was diagnosed after excision of a benign lesion. There were 11 patients with at least 2 radial scars at biopsy. 8 or 72.7% underwent excision of all radial scars without upgrade. 2 or 18.2% had unchanged imaging findings after 2 years of follow-up, and 1 or 9.1% was lost to follow-up. In the multiple AD group, there were 12 benign lesions at biopsy. 5 were excised due to discordance, demonstrating 1 radial scar, 1 FEA, and 3 benign lesions. And 1 benign concordant lesion was excised at the time of ipsilateral lumpectomy without upgrade. Of 10 benign lesions, 4 were excised without upgrade. 4 showed no evidence of malignancy after a mean of 27 months of imaging follow-up, and 2 were lost to follow-up. For single and multiple AD combined, the overall upgrade rate to malignancy at excision for benign lesions at biopsy was 11.5%. For high-risk lesions at biopsy, 3.6%. For radial scars without atypia at biopsy, 0%. And for radial scars with atypia at biopsy, 4.2%. Of 30 patients with multiple AD, 13 or 43.4% had malignant pathology, 15 or 50% had high-risk pathology, and 2 or 6.7% demonstrated benign pathology. This graph summarizes the distribution of benign, high-risk, and malignant pathology among patients with 2, 3, and 4 biopsied areas of AD. In patients undergoing biopsy of 2 areas of AD, most aggressive pathology was malignant in 46%, high risk in 46%, and benign in 8%. In the 3 patients undergoing biopsy of 3 areas of AD, most aggressive pathology was malignant in 33% and high risk in 67%. In the 2 patients who underwent biopsy of 4 areas of AD, high-risk pathology was obtained at all 4 sites. The distribution of most aggressive pathology was not significantly associated with the number of biopsied AD. This table summarizes patient-level combinations of pathologic outcomes for patients with 2 ipsilateral biopsied AD. Among the 19 patients with 2 ipsilateral biopsied AD, 5 patients had varying pathology. In 5 patients undergoing biopsy of 2 contralateral AD, 2 demonstrated varying pathology. Of 3 patients undergoing biopsy of 3 areas of AD, pathology varied in all 3. And in 2 patients undergoing biopsy of 4 areas of AD, high-risk pathology was obtained for all sites. In 8 of 24 patients with at least 2 ipsilateral AD, most aggressive pathology varied. In 5 of 10 patients with contralateral biopsied AD, contralateral pathology varied. Overall, 10 of 29 patients who underwent biopsy of multiple AD showed variation in most aggressive pathology. This graph shows the distribution of benign, high-risk, and malignant pathology for single and multiple AD groups based on the presence or absence of an ultrasound correlate. And in both these single and multiple AD groups, malignant pathology was more likely in the presence of an ultrasound correlate. The frequency of ultrasound correlates was not significantly different between single and multiple AD. However, frequency of malignancy was significantly higher in the presence versus absence of an ultrasound correlate for both single and multiple AD groups. In absence of an ultrasound correlate, malignancy rate was 10.9% in single AD and 5.3% in the multiple AD group. MRI was performed in 13.4% of patients with single AD. The vast majority of these were for extensive disease. An enhancing correlate was identified in 48 of 50 AD, including 27 masses and 21 non-mass enhancement. In the multiple AD group, 36.7% of patients underwent MRI. Again, the vast majority of these were for extensive disease. An enhancing correlate was identified for all 28 AD, including 12 non-mass enhancement, 9 masses, 4 AD with enhancement, and 3 biopsy cavities with rim enhancement. MRI was significantly more likely to be performed in patients with multiple than single AD. MRI enhancement pattern, defined as mass versus other, was not significantly different between single and multiple AD. For biopsied AD evaluated by MRI, the frequency of malignancy was significantly higher for single compared to multiple AD. And just to show some examples now, this is an 82-year-old woman. She was recalled from screening mammography for distortion in the upper central and lower outer left breast. An ultrasound correlate was identified for the distortion in the upper central breast, and ultrasound biopsy demonstrated invasive ductal carcinoma. No ultrasound correlate was identified for the lower area of distortion, and DBT biopsy demonstrated invasive lobular carcinoma. This is a 72-year-old who was recalled from screening for 2 areas of AD in the upper outer left breast. Ultrasound biopsy of the more posterior area of distortion demonstrated invasive lobular carcinoma. No ultrasound correlate was identified for the more anterior distortion, and DBT biopsy revealed stromal fibrosis. This is a 68-year-old woman who was recalled from screening for bilateral AD. Ultrasound correlates were identified for both areas. Ultrasound biopsy on the right demonstrated high-risk pathology of an intraductal papilloma, and ultrasound biopsy on the left demonstrated an invasive lobular carcinoma. This is a 57-year-old woman who had biopsy-proven radial scars at 12 o'clock in both breasts, indicated by the arrows, found to have 2 additional areas of AD in each breast. Ultrasound correlates were identified for all 4 areas, with representative images seen here. Ultrasound biopsy demonstrated radial scars. There was no upgrade at the time of surgical excision. On follow-up breast MRI, AD with enhancement was seen at 3 o'clock in the right breast, and MRI biopsy revealed grade 3 DCIS. This is a 55-year-old who was recalled from screening for AD in the central left breast, seen only on CC view. This persisted on spot compression view, and no ultrasound correlate was identified. She proceeded to undergo DBT biopsy, which demonstrated stromal fibrosis. On subsequent screening breast MRI, you can see the clip artifact with no corresponding suspicious enhancement, and this area has been stabled on 3 years of mammographic and MRI surveillance. In our study, we found that compared to patients with single AD, patients with multiple AD are more likely to have concurrent breast cancer or concurrent high-risk lesion. Multiple AD compared with single AD was significantly more likely to yield high-risk pathology, but was not significantly different in frequency of malignancy on a per lesion or per patient basis. On multivariable analysis, concurrent breast cancer was independently associated with a higher likelihood of malignant pathology, whereas concurrent high-risk lesion was independently associated with a lower likelihood of malignancy. Multiple AD was not independently associated with the likelihood of malignancy. In patients with multiple AD, the number of areas of AD was not significantly associated with malignancy. In addition, multiple ipsilateral or contralateral AD commonly varied in terms of pathology classification, and therefore biopsy of all areas may be warranted given variation in pathologic diagnoses. Single and multiple AD did not differ in terms of frequency of an ultrasound correlate. As shown in other studies, presence of an ultrasound correlate was significantly associated with malignancy for both single and multiple AD. The malignancy rate without an ultrasound correlate was 10.5% for single AD and 5.4% for multiple AD, highlighting the need for tissue sampling even in the absence of an ultrasound correlate. In our series, the upgrade rate was 0% for radial scars without atypia and 4.2% for radial scars with atypia. This is within the range reported within the literature and supports observation as a reasonable alternative to surgical excision for radial scars without atypia, especially in women with multiple radial scars. Utilization of problem-solving MRI for AD remains an area of interest. In the current study, MRI was uncommonly performed for this purpose, with the majority performed for extended disease. Biopsied AD evaluated by MRI was significantly more likely to be malignant for single than multiple AD. However, MRI enhancement pattern was not significantly different between single and multiple AD groups. There are several limitations to our study. This was a retrospective study from a single institution. The number of patients with multiple AD was small. In addition, data was based primarily on review of radiology reports. In patients with multiple AD, correlating individual areas of AD across different mammographic projections can be challenging, introducing observer variability. The optimal role of MRI in management of multiple AD is unclear from our data, and we did not evaluate stability of AD with respect to earlier DBT exams. In addition, single and multiple AD were not compared in terms of long-term outcomes. Lastly, the upgrade rate to malignancy at surgery of benign lesions at biopsy was high at 11.5%, although within the range reported in other studies. In summary, women with multiple AD compared to women with single AD were significantly more likely to have concurrent breast cancer or concurrent high-risk lesion, and significantly more likely to have high-risk pathology. Malignancy was independently associated with concurrent breast cancer and concurrent high-risk lesion, but not with the presence of single versus multiple AD. The number of areas of multiple AD was not significantly associated with malignancy, and multiple ipsilateral or contralateral AD often yielded varying pathologic outcomes. In conclusion, multiple compared with single AD showed a higher frequency of high-risk pathology, but no difference in frequency of malignancy. For patients with multiple AD, biopsy of all areas may be warranted given variation in pathologic diagnoses across areas of AD in individual patients. Thank you for your attention.